There is a curtain in every operating room. It's blue, it's about 5 feet tall, and it separates the surgical field from the patient's head. The surgeons call it the drape. Anesthesiologists call it the ether screen, even though nobody has used ether in 70 years. On one side of that curtain, 3 or 4 people in sterile gowns are hyper-focused on a single organ, a gallbladder, a knee, a tumor. On the other side of that curtain, alone, sits one person managing every other organ in the human body in real time, while keeping the patient simultaneously unconscious enough to be cut open and alive enough to wake up. Their heart, their lungs, their kidneys, their brain, their blood pressure, the depth of their amnesia, the level of their paralysis, the temperature of their core, the pH of their blood, all of it every 6 seconds for as long as the surgery lasts. That person is the anesthesiologist. You are about to become one. Stage 1, medical student. You are 24 years old. You have been in medical school for the last 2 years. You are looking into your potential future career path. You have heard about road specialties and have been told that anesthesia is the easy specialty, the gas passers, the doctors who get paid over $500,000 a year to do crossword puzzles in the dark. You believe this until the 3rd week of your 3rd year when you scrub into your first surgical case as a medical student. The surgeons are talking about a fishing trip. The scrub tech is restocking sutures. You're standing on a step stool holding a retractor, and you're trying not to faint. You glance over the drape. There is a woman behind it that you hadn't noticed when you walked in. She is 38 years old. She has been doing this for 11 years, and she has not looked up from her monitor in 7 minutes. Her name is Dr. Patel. She nods at you. You nod back. You do not speak because the moment you speak would be the wrong moment. Then the patient's blood pressure drops. You don't see it. The surgeons don't see it. Dr. Patel is keeping an eye on it. She reaches up without looking, turns a dial, picks up a syringe, pushes 1 milliliter, sets the syringe down, and writes something. The blood pressure comes back up. 45 seconds total. The surgeons keep talking about the fishing trip. They never knew anything had happened. This is the moment. You realize, standing on that step stool, that everyone you've ever met has been wrong about anesthesia. The surgeons are doing carpentry on a single organ. Dr. Patel is flying the entire human being through the procedure, alone. And the measure of how good she is at her job is whether anyone notices her doing it. You watch her for the rest of the case. At the end, when the patient starts breathing on her own, when the eyes flutter open, when the patient says, "Did it go okay?" Dr. Patel just smiles and says yes. The patient never thanks her. The patient won't remember her face. That, you understand suddenly, is the point. You apply anesthesiology and thankfully match into your #1 program in another state. Stage 2, intern year. You are 26. You signed a contract for $68,000 a year. You owe $278,000 in loans. You will not see the inside of an operating room as a doctor for another 8 months. Here is what nobody tells you about the transitional intern year for an anesthesia-bound resident. It is its own specific kind of suffering. Anesthesiology training is structured strangely. Before you ever touch an anesthesia machine, you have to spend a full year as a medical or surgical intern. 12 months of admitting patients, writing discharge summaries, rounding on the medicine ward, managing diabetes and hypertension and social problems that have nothing to do with the OR. Your co-interns who are going into internal medicine, ED, and surgery are learning the job they will do forever. Their pages, their rounds, their progress notes, those are reps for their actual career. Every long hour is an investment. You are doing reps for a job you will never have. You spend an hour adjusting a 70-year-old's insulin regimen, and you find yourself thinking, without meaning to, about how fragile he would be on induction. You round on a confused 80-year-old, and you listen to her lungs, and you catalog, automatically, what her airway would look like under a laryngoscope. The receding jaw, the Malempity 3, the neck that doesn't extend. You discharge a patient on 16 medications, and you read through the list twice, not for the discharge summary, but because you want to know which ones would interact with a volatile agent and which ones you'd have to hold the morning of surgery. You are doing the job in front of you. You are doing it well, mostly, but your mind has already gone ahead of you, down the hallway, into the OR, to a table you haven't stood at yet. You are restless in a way the other interns aren't. You don't say it out loud because there's a culture of earn your stripes, and you don't want to seem like you think you're above the work. But every shift, somewhere in the back of your head, a clock is running. 8 more months. 6 more months. 3. One night, a patient on your ward goes into respiratory distress. The anesthesia resident on call comes up to intubate. You stand in the doorway and you watch him. He is 28 years old. He is wearing a Patagonia fleece over his hospital scrubs. He hooks the patient up to a bag valve mask, pre-oxygenates for 30 seconds, pushes etomidate, pushes succinylcholine, waits until the patient's eyelid stops twitching, slides the laryngoscope blade in, finds the cords on the first attempt, drops the tube, confirms with end tidal CO2. The whole thing takes 90 seconds. You watch his hands. You think, that's me. In 7 months, you go back to the workroom and finish your discharge summary at 2 a.m. You feel, for the first time since June, something like hope. Stage 3, Clinical Anesthesia Residency, July of CA, 1 year. You are now, officially, an anesthesia resident. They give you a long white coat, a beeper, an OR assignment, and a folded sheet of paper with the a difficult airway algorithm on it. They tell you to keep it in your pocket. You will keep it in your pocket for 3 years. Your first month is gentle on purpose. Healthy patients. Routine cases. You learn to set up the room, the machine check, the suction, the IV, the monitors. The drugs drawn up and labeled in the order you'll push them. Propofol, white. Succinylcholine, clear. Fentanyl, clear. Phenylephrine in a bag, hung. Atropine on the cart, just in case. Then the cases get harder. The first time it happens to you is a Tuesday morning. The patient is a 46-year-old woman, BMI of 41, scheduled for a laparoscopic cholecystectomy. The pre-op anesthesiologist's note says, anticipate difficult airway. You ignore this because you are a CA1 and you've successfully intubated 30 patients in a row, and you are starting to believe you are good at this. You push the propofol. You push the sucs. You wait until the twitches stop. You position the head, you slide the blade in, and you see nothing. No epiglottis, no cords, just the back of the tongue and a faint pink wash of tissue. Grade 4 view. You don't say anything. You pull the blade out, you bag mask her. The bag feels stiff. The CO2 waveform on the monitor is flat. The pulse oximetry tone, which had been a steady high beep, drops half a step. Then another half step. The attending, who had been standing by the door, is now next to you. He doesn't take over. He says very quietly, try again, different blade. Reposition. You have 90 seconds before we go to the LMA. You can feel your own heartbeat in your throat. You change the blade. You reposition the head. You go back in. The pulse ox tone is descending. 88, 86. You see the epiglottis. You lift. You see the cords. You slide the tube. You see chest rise. The CO2 waveform appears on the monitor. 6 perfect square waves in a row. The pulse ox tone climbs back up. The whole thing takes 4 minutes. The surgeon walks into scrub. He has no idea anything happened. The attending nods at you and says, good recovery. You go to the bathroom between cases, and you sit in the stall, and you put your head in your hands, and you do not cry, but you stay there for a long time. That night, you read the a difficult airway algorithm again. You read it the way you read scripture. CA 2 year, something shifts. The cases get harder and you get faster. You learn the rhythm of the room. You learn that the surgeon who says, I'm just closing, actually has 45 more minutes of work to do. You learn that when the surgeon asks for more relaxation, the patient is already as paralyzed as a human being can be. Train of 4 shows 0 twitches. And what the surgeon actually needs is a different table angle. You learn to nod and say, I'll see what I can do, and not change a thing. And the surgeon will say much better 3 minutes later. You learn the dark thing too. You learn it in a lecture on a Wednesday morning in November of CA2 year, given by the program director. She tells you that anesthesiology has one of the highest substance use rates of any medical specialty. She tells you that the first sign of a colleague's addiction is often not lateness, not poor charting, not strange behavior, but a code blue in the call room. She tells you to look for pinpoint pupils. She tells you about the witnessed waste protocol, the random urine screens, the new refractometry checks on returned syringes. She tells you that the very tools you use to heal people are the ones most likely to destroy you. Nobody talks during the lecture. Nobody jokes about it after. There is a chance that one resident in your class who, 4 years later, will not be there anymore. You will not be told why. CA 3-year, you become the senior. You see your CA1 panicking over and immediately reaching for a massive bolus of phenylephrine as the alarm of a patient's blood pressure plummets to 70/35 shortly after propofol induction and the start of positive pressure ventilation. You calmly point out that the patient is deeply anesthetized, entirely vasodilated, and likely volume depleted from preoperative fasting, and advise administration of a much smaller measured dose of ephedrine while opening up the IV fluids and gently dialing back the volatile anesthetic, explaining that treating the underlying physiology is always safer than blindly chasing a number on the monitor. You realize you have stopped translating physiology in your head. You are now just feeling it. Stage 4, OB Anesthesia Fellowship. Most anesthesiologists finish residency and go straight to attending. You don't. You do a fellowship because you have decided you want to take care of the most physiologically unforgiving patient in the entire hospital. You become an OB Anesthesia Fellow. Cardiac anesthesiologists will tell you their job is the hardest. They have the bypass pump, the ECMO, the transplants. They have the drama. You disagree quietly, because in cardiac anesthesia, you have one patient. In obstetrics, you have two. And in obstetrics, the second patient is one whose heart rate you cannot directly measure, whose airway you cannot access, and whose entire prognosis depends on the first patient not crashing. Every pregnant patient is, anesthetically, a nightmare. They have a 50% increase in blood volume, a cardiac output that spikes 80% immediately after delivery, edematous airways with Malampati scores that drift up 2 grades during pregnancy, and they are all considered full stomachs, meaning if you have to put them under general anesthesia, you have about 30 seconds before the gastric contents become a problem. Your fellowship is 12 months of standing at the heads of beds while women have babies. Your shift begins at 6 a.m. Your first epidural is at 6:15. A primigravida at 4 centimeters, contractions every 3 minutes, screaming. Her husband is pacing. You sit her up on the side of the bed. You find the L3 to L4 interspace by feel. Through 6 inches of edematous tissue, through a back you cannot see, and you place the needle. Loss of resistance. You thread the catheter. You dose it. 20 minutes later, she is laughing with her mother on FaceTime. The husband shakes your hand. You leave the room and forget the ordeal within an hour. 11 a.m. Your pager goes off. Category 1, C-section. Cord, prolapse. You run. The patient is on the bed. The obstetrician's hand is inside, her holding the baby's head off the cord. They are running her down the hallway. You meet them at the OR doors. You have 90 seconds to get the patient asleep, intubated, and the surgeon's cutting. Your spinal from this morning won't work. There's no time. General anesthesia. You pre-oxygenate her in the elevator. You push the drugs in the OR. The intubation is a Malampati 4, and you see the cords for 1 second. You drop the tube. The surgeons are cutting before the tape is on. Baby is out in 3 minutes. Apgars are 7 and 9. The mother does fine. You will think about that intubation every night for 2 weeks. You do this for a year. By the end, you are the person other people call when they don't know what to do. Stage 5, attending anesthesiologist. You finish fellowship at 32. You sign your first attending contract at a large academic medical center in a Midwestern city. Your starting salary is $420,000. You start paying off your loans aggressively. You buy a small house. You meet someone who is not a doctor and build a life together. Your job is labor and delivery. You are the OB anesthesia, attending on service 12 days a month, plus calls, plus a shared pool of general OR days to keep your broader skills current. Your day begins at 6:15. You round first. 5 active labors, 2 scheduled C-sections, 1 induction of a woman with a history of an awful previous delivery who is terrified of everything. You go to her room first. You spend 15 minutes with her. You explain what the epidural will feel like, what it won't feel like, what the complications are in a way that does not scare her more than she is already scared. You tell her you'll be the one placing it. She cries a little and thanks you. You leave the room knowing you have just done the most important thing you will do today, and it had nothing to do with the needle. By 10 a.m., you've placed 4 epidurals, done a scheduled C-section under spinal, and you're sitting in the workroom eating a granola bar when the pager goes off. Category 1, cord prolapse. Room 12, you run. You have done this 22 times since fellowship. You still run. The patient is the woman you consented this morning, the terrified one. Her epidural is in, but hasn't been dosed up for surgical levels. There is no time. You convert to general anesthesia. In the hallway, on the way to the OR, you push the drugs, you intubate. The baby is out in 2 minutes. The mother does fine. An hour later, when she wakes up in the recovery room and you're standing next to her, she grabs your wrist and says, "You were there the whole time." You tell her, "Yes, you were." She falls back asleep, still holding your wrist. 3 years in, you have your case. Every OB anesthesiologist has one. You don't pick it. It picks you. A mother who did everything right and whose physiology did something it shouldn't have. You did everything right. You can prove you did everything right. You will go back over that case in your head every restless night for the next 11 months, and you will not find the mistake. Because there isn't one. The mother should be here. She is not. She did not leave the hospital, and neither did you as the same person. The baby survived. You sit in the OB anesthesia call room at 2 a.m. the night it happens, and you talk to the only other OB anesthesiologist who is still awake. She listens for a long time. Then she says, "I have one of those too, the one in 98. I think about her every time I dose an epidural." You nod. You do not say thank you. She does not need you to. This is the part of the job they really do not tell you about. You will carry her. You will carry all of them eventually. You also, between the carrying, quietly preside over thousands of deliveries that go right. Women who arrive in pain and leave with a baby. Women who thought they could not do it until you walked through the door. Women who will never know how close some of those moments actually got, because you never told them, and you never will. That, you have understood for a long time, is the job. Stage 6, Senior Anesthesiologist. You are 58. You stopped taking overnight call 2 years ago. In OB, that's a bigger deal than in most places. Babies don't honor daytime hours, and giving up call means giving up half the job. The conversation with your partners took 18 months. The math, in the end, was simple. At 32, you could run a crash C-section at 3 a.m. and be back at work in the morning. At 56, you could still run it, but the cognitive hangover for a day or two. You took the pay cut. You don't regret it, and you try to prioritize work-life balance. You take up gardening to bond with your spouse in your forever home. You work days now. You cover the scheduled C-sections, the high-risk pre-op clinic, the medically complex moms who need a full hour of counseling before anyone places an epidural. You are the person they call when they don't know what to do. You are increasingly one of the people the program asked to give the lecture nobody wants to give. Last year, you gave the substance use disorder lecture. You knew 2 of the people on the slide. You did not say so. A few months ago, in the grocery store on a Saturday, a young woman stopped you in the produce aisle with a toddler on her hip. She said, "Are you Dr. Okafor? You did my epidural 2 years ago. I had the emergency C-section. You were the one who held my hand in the elevator. I don't think I ever thanked you." You did not remember her. You told her you did. You asked how the baby was. She introduced you to her son. He waved. You went home. You made a cup of tea. You sat at your kitchen table for a long time. You thought about your legacy, the way people in their late 50s do. Your colleagues in obstetric surgery have named procedures. Your colleagues in neonatology have outcomes data. Your colleagues in academic medicine have papers and chapters and named lectures. You have none of those things. What you have instead is this. In a 30-year career, you have personally delivered anesthesia for somewhere between 12 and 15,000 births. Almost none of the mothers remember your face. Almost all of them remember the feeling of someone calm standing behind them during the worst pain of their lives, of someone explaining what was happening when everyone else was too busy, of someone who was the last thing they saw before a crash C-section and the first thing they heard afterwards. Almost all of them are still alive, Almost all of the babies are 2. In residency, they teach you that a good day is when the patient doesn't remember you. They were half right. 12,000 mothers in, you finally understand the other half. The patient doesn't have to remember you for it to have mattered. You are happy with your impression being washed away, as long as the current takes the pain they experienced along with it. But sometimes, every once in a long while she does, and that mattered too. Hope you enjoyed this video. Subscribe for more videos.